Number one, true or false? Low bone density is only a concern for older women.
False. As an older man, I'm offended.
Number two, can strength training actually improve bone density and not just maintain it?
Absolutely.
Walking. Walking alone is enough to prevent osteoporosis.
Big fat false.
Number four, does improving muscle strength and balance significantly reduce fall risk?
Yes.
And one myth about low bone density or osteoporosis, falls, aging that you wish people would stop believing. Welcome to a lovely episode on hormones and hope. This is your host, Dr. Makhija. And today I have a very important guest, especially my patients who have low bone density, osteopenia, osteoporosis. You can't miss this episode because I have a guest who is a physical therapist, who has a doctorate degree, and also is Onero-certified. You'll get to know more about what this exactly means. But a physical therapist who has a doctorate, who is also trained in helping you build your muscle, build your bone strength, and there has been enough evidence that by doing so, we can see improvement in bone density. So, without further delay, it's my pleasure to introduce you to Dr. Robert Pauline, who is a physical therapist in Central California. And he's got an amazing clinic called Robert Pauline Hands on Physical Therapy in Fresno and Clovis, California. I've personally visited. It's a phenomenal place to be in. I've actually met with several of his clients and have a few more patients who've told me about him and how he works with patients in terms of their functional improvement and not just one specific joint or an injury. So, welcome, Dr. Pauline.
Thank you. I'm honored to be here, Dr. Chhaya, if that's okay if I call you that.
Absolutely.
Call me Dr. Robbie. I've tried to outgrow Robert, and it's still just Robbie. So we are so honored to work with patients in the Central Valley. I had a close friend of mine a couple years ago come to me and tell me, I have a problem and I need you to help me solve it. And she had gone through menopause and kind of put this problem in my face. It was the fact that she was worried about her bone density. She was a drug rep for some of the bisphosphonates and anti-resorptive drugs for many years, so she knew all of the risks and some of the risk benefits to those drugs, and she came to me and said, "You're gonna be my guy." And she put this, challenge in front of me, and it really did sort of turn upside down the way we've been dealing with osteoporosis in the past. So I'm a licensed physical therapist with a clinical doctorate, so it's a DPT, and I'm also an orthopedic certified specialist. And so I believe that physical therapists are uniquely qualified to work in this space, but it wasn't a space that I had been in until Carol, my high school friend, came and just challenged me to help her.
Okay, okay, very cool. Well, I'm excited to, to have my audience as well as patients hear more about this. And if someone's watching on YouTube, they'll be even able to meet you if you had to reach out to Dr. Robbie. But before we dive into our usual Q&A and rapid fire, Dr. Robbie, if you can, in maybe couple of lines, tell us what is this Onero program that we are talking about today before we get into the nuances later on.
The Onero program was born out of a study called the LIFTMOR trial in 2018. A bone researcher set out to try something different for people with low bone mass, and they started treating osteoporosis patients like athletes. And they, under really close supervision and proper training, started doing intense resistance and impact training. So this is a high intensity resistance and impact program that carefully screened individuals can participate in. My mantra is to start low and go slow. And so before anybody ever picks up weight, we work on foot stability, balance, strength, get to know their joints, their soft tissues. A lot of our patients have postmenopausal musculoskeletal syndrome, pain in their elbows, knees, hips, or they have a history of back pain. So we start slow and we build up gradually to the point where several of our patients are now deadlifting their body weight. And so it does eventually end up being heavy. And that's something that is really amazing how the body adapts and how these people who are new to weightlifting can learn the skill and develop the ability to pick up heavy weights.
Yeah, yeah, absolutely. As endocrinology and, in this lifestyle medicine world too, um, we've been focusing on muscle, on, building it and more strength training also for insulin resistance, for, reducing the diabetes complications or even, getting diabetes into remission. And of course, the other metabolic conditions that also we see an improvement. But the other aspect is, with the era of weight loss medications, even though we've had it for 20 years, but with the media bringing it in, if there is significant weight loss, there is going to be more bone loss or lean body mass loss. So in these patients, they have to like really be trained in regards to how to work on your muscle, how to improve the strength, and also build that extra muscle fiber so that you don't lose muscle and don't lose bone and don't have future low bone density. So, what discussion we're going to have, I feel it's going to be in the realm of lots of other conditions and health rather than only individuals or people dealing with low bone density.
Yeah, absolutely.
Yeah. So, Dr. Robbie, we'll start with a rapid fire. This is just more fun for one-liner or one-word answers, and then we get to really learn about the strength training or how you approach patient care in terms of helping them to get stronger. You ready?
Let's go.
Number one, true or false? Low bone density is only a concern for older women.
False. As an older man, I'm offended.
I love that answer. All right. Number two, can strength training actually improve bone density and not just maintain it?
Absolutely.
Walking alone is enough to prevent osteoporosis.
Big fat false.
Thank you very much. Number four, does improving muscle strength and balance significantly reduce fall risk?
Yes.
All right. And one myth about low bone density or osteoporosis, falls, aging that you wish people would stop believing.
That it's a normal part of aging. It's not normal.
Sweet. Absolutely. Yes. We get younger with you, Dr. Robbie. So you have the miracle mantra here. I love it. I love all the answers and completely 100% with you on those. Okay, so where do we want to start? You told us about the Onero program, but can we get into more details about the LIFTMOR clinical trial? And I can give you some background. We have patients with, osteopenia or osteoporosis, and many individuals with severe osteoporosis. And, we have certain ways to prevent. We have guidelines telling us that weight bearing exercise or working on strength training will help you to build bone. We have hormone replacement therapy to prevent osteoporosis in individuals who have low bone density in women, and then we have medications, pharmacological medications, which either you build bone or you just preserve what you have. So there are always questions that what can I do naturally, which is always a question from patients that can help me. And this is where I stumbled upon, I think it was Bone Health Osteoporosis Foundation, where they talked about the LIFTMOR trial. And that intrigued me. That's how I, went through this website, Onero program, and discovered that you were one of the certified teachers in our neighborhood, and that's how we met. So, can you break it down in terms of if you want to start with the actual trial, like what was done to see the results for those patients, and then about how you approach your patients?
Sure. I hope it's okay to just take just a little side route and talk very briefly about anabolic resistance. You mentioned earlier in metabolic syndrome, we see insulin resistance. As we age, we see anabolic resistance, or just the body's sort of resistance to growth. We sort of believe that breakdown happens slowly over time, and we have these metrics as far as how much muscle mass you can expect to lose over time. And so one of my biggest hurdles is going to be anabolic resistance. And there's certain ways to signal growth in the body. You mentioned a couple of them: nutrition, medication, the lifestyle activities, and then obviously exercise. And so when we're taking somebody and trying to create an environment for them to grow something, whether it's muscle mass or bone mass, you have to get a really clear picture of where they're starting. And so the LIFTMOR trial did a very good job of screening out complications because they didn't want to have to deal with people with arthritis or back pain or, prior history of fracture. And so the LIFTMOR trial is a group of very healthy women and a few men who happen to also have low bone mass. So the inclusion criteria in the study really screened out for some of the things that I deal with every day. And so I'm very cautious to say, okay, this worked for these 49 women or 49 participants. So it's going to work for all my patients, right? So the LIFTMOR trial had 101 participants, 49 lifters, and 52 in the control study. The control were people who were advised to walk and lift light weights for 30 minutes, 2 to 3 times a week. The participants in the study were supervised and taught some very specific compound movements. And these would be very similar to Olympic weightlifting. And they were taught how to do them safely, supervised every session. This was not a learn how to do these lifts and go do them on your own. They had eyes on them in groups up to 8 people, and they lifted weights for about a half an hour twice a week for 8 months. And they really wanted to do a year, but the study had some limitations in funding, and so they did 8 months and then retested bone mass. They retested muscle mass and then some functional measurements for balance and fall risk. And just across the board, they saw remarkable improvements in every one of those domains. Also, because the control group lost over 8 months, they lost a little bone, they lost a little muscle because what they were doing was not building. And so, just over time, they lost. And so you have some high percentages, but you have to remember that it's also the those numbers of improvement account for the loss in the control group. So when somebody goes and gets their DEXA scan and they say, well, this trial showed 3% improvement in the lumbar spine, why did I only have 1 or 2% improvement? You're comparing yourself to yourself, not yourself to a control group. So we have to just help patients sort of have a realistic expectation of what they might expect to happen in their testing. But we typically see significant improvements in balance, single limb stance, tandem walking, functional reach, sit to stand. We see improvements in those measurements regularly. And we're not running off and getting repeat DEXA scans every 6 months. Like, that's just not how you work clinically. But those that have had repeat DEXAs have shown significant improvement. One of our most favorite lifters had a 7.5% improvement in her lumbar spine and hip. She is on an anti-resorptive drug, but had been on that for a long time, and her numbers had kind of been pretty flat, and so it was maintaining. But I kind of ran off with that response. Is there any element of the LIFTMOR trial you want me to double click on?
No, that's pretty robust in terms of the way you described. And I really loved what you said about the realistic expectations and the aging process of the muscle and the bone. You don't use as much. There is sarcopenia bound to happen, especially in the 70s, 80s, 90s. And same thing with bone. We tend to lose bone after we've achieved our peak bone mass in our early 20s. That cannot be prevented, but it can slow down with what you're sharing with us. And if someone has, say, no bone loss, and they're getting day one bone density and again in 2 years, but they are building muscle, they've improved their balance, they're performing like what you were mentioning about strength training, and they don't have any bone loss on bone density, that itself is positive because they did not lose anything relevant to the age. Yeah. So the realistic expectations, and educating the patients in terms of what they're going to accomplish, was very well said. And can you share any other patient experience that you've had in terms of how do you start? Like, say I'm a 65-year-old female and I've just learned that I have either osteoporosis or severe osteoporosis in the spine, and the numbers are kind of similar in the hips, and I'm going to be on a specific medication, but you're trying to help them start. They only are good with walking and maybe taking care of, daily home chores, climbing stairs. But other than that, they've never been to the gym, they've never worked out, they've never lifted anything heavy. How would you start someone on this journey?
Yeah, it's a lot of fun to take a brand new lifter or someone who's just found out about a osteoporosis diagnosis and bring them in and just sort of wrap our arms around them and help them to see that we have a plan and that we are one piece of a comprehensive approach to their bone health. I don't try to play family physician. I don't try to play endocrinologist or even nutritionalist, right? I'm happy to play my role. And so one of the first things I do is have people take their shoes and socks off. I want to see what I'm working with. If they're going to pick up some weight, I need to get to know their feet. And so I get to know their feet, their big toe. They don't know what I shouldn't, maybe I shouldn't spoil it here on this podcast, but when they stand up and down out of a chair, what does their big toe do? Is it sticking up in the air like a little antenna, or is it to the ground and providing stability? I'd like to see how their knees move. Do their knees come together? Do they have strength to get out of a chair? Is there pain getting up and down out of a chair? So, one of our very, very first tests is how many times can you stand up and down from a standard chair in 30 seconds? If you're under 10, you're in trouble. Usually, our 60-year-olds between 60 and 65, somewhere between 10 and 15 sit to stands is normal. If they're over 15, I think, okay, I can move this person along a little bit quicker. Then we look at single limb stability. How do they stand on one leg? Under 15 seconds, they're in trouble. Over 30 seconds, I can probably move this person along a little bit quicker. Then I look at heel to toe walking over the course of 6 meters. If they're under 20 seconds, I'm thinking I can work with this person and move them quicker. If they're over 20 seconds and they have stumbles and a lot of missteps, then we're going to have to start a little lower. And then I look at a functional reach test. How far can they reach over their base of support without losing their balance? Under 12 inches, we start a little bit lower. Over 12 inches, we move a little bit further. And Obviously, that is after a very thorough medical screening. We'll look at their medication history. I'll look at their supplements and see what they're taking, how often, their compliance. I'll talk about nutrition. If they're not tracking, we'll ask them to start tracking protein intake. And then we talk about the orthopedic history, surgeries, injuries, chronic pain. I will probably palpate in the usual areas where problems exist: elbows, hips, knees, feet. I'll look at the spine, looking at any potential modifications we have to make if they're kyphotic. We measure kyphosis with a really simple test, and we get a really thorough baseline. I'll often get body mass index and measure lean mass using bioelectrical impedance and just get a really solid starting point. So that's the first visit, sometimes first and second visit, depending on how long their medical history is. So that's my true starting point. And then in subsequent visits, we really start to reintroduce people to their feet. We like to put our feet in tight oven mitts and ask them to do complex things like walking and stabilizing. Our shoe wear in this country is mostly horrible. I do have some various patients who come in a barefoot style shoe, and they're always going to perform way, way better than people in their Nikes or Under Armours or other traditional shoes. So we typically will have people start several of their exercises barefoot, if possible. If there's a complex history there at the foot, then we work with that and we work around it. And then we're teaching a very important concept called the extensor moment of the spine. How to maintain a spinal neutral while hinging at the hips. So we really get to know their body awareness and give them lots and lots of visual feedback. We move with PVC pipes for weeks before we ever pick up their first weight. And a lot of it is slow, but people appreciate that. It's very refreshing when people aren't frustrated at the slow process. They almost always thank me for taking my time and not rushing it along. So the beginning stages are technique, body awareness, stability training, and we start to introduce a lot of balance activities in that early stage as well.
This is very important that you mentioned. I'm from India, and that's where we learn yoga. And while I was here, Fresno, you probably know Audrey Tan, but she used to be my yoga teacher for a long time. And the concepts of your foundations and making sure there is enough room in between your toes, and how do you make sure that you're able to wriggle every toe, and your balance, and how are you standing, your posture. When we grow up, it's like, what the heck? This is not exercise. It doesn't feel right. But over time, as I, became a physician, and then of course, things coming back, and now I am learning it over and over again, that these simple foundations are technically simple, but they're the ones which are helping us ground. And then you're building on the actual strength part of it, but the posture, the stability that you talked about, because that's going to help us prevent fractures, prevent falls. But you know what I thought while you were expressing all this, that this is not just needed for that 65-year-old female that we were talking about. I feel each adult, every person needs that exposure and understanding and expertise. That can someone assess me how I'm grounded when I am standing? And I see most of them are not. And I so agree with what you mentioned about us wearing closed boots and limiting that or worsening our foundations. So, do you talk to your young adults about this?
Oh yeah, for sure. In fact, the being certified in Onero has really changed the way I even work with young athletes. One of my favorite young ladies that I have had the privilege of working with after an ACL injury. She's 15 years old now. She's been with me for about a year. She had a complex ACL rehab and was still very weak 8 months later. We're teaching her these same principles, and she is now doing compound lifts with symmetry. She's jumping, and there's impact. She wasn't going back to a sport, but we're treating her like an athlete, and absolutely translates into the young. You mentioned that there's a peak for bone development. I would love to hear you speak a little bit more about how a young teenager, especially maybe one at risk for osteoporosis, what they might do as an adolescent to build the most bone so they're starting off at the highest possible lean mass. Any thought on that?
Yeah, yeah. See, I'm an adult endocrinologist, but I can tell you about pediatric bone age too. You know what? In this era, what we're seeing is our adolescent age group, both girls and boys. There is this trend of being thin. There's a trend of eating disorders which is dramatically increased, and I see more and more boys like 16-year-old 18-year-old presenting with these or being referred to me for these symptoms, some other hormonal disorder that they are getting evaluated by me, but when I'm digging into the depths, it's like low caloric intake. And all of these individuals, after looking at their biochemical evaluation or labs, I get a bone density scan for that young adult. And I'm surprised to see, not surprised, but I would say shocked to see that they've probably been in that low caloric deficit for a few years during their building period. And that's leading to, that abnormal bone density. It's also called as female athlete triad, which we were seeing only in women. Again, athletes, runners, their energy expenditure is higher than the caloric intake. And that's where we see low bone density. But now I've started seeing in the last 8, 9 years more boys. And this is also wetted by, I've had a few interviews with psychiatrists, ADHD specialist, a pediatrician actually interviewed on our podcast from San Francisco. And she's been noticing that trend as well. So in those individuals is what I think it's a lot of is the caloric deficit rather than true hormonal abnormalities, which can happen, which is a disorder and can be treated. But that caloric intake versus energy expenditure has caused poor bone development, and so they cannot reach their peak bone mass at that age. The second one is the lifestyle. So, like at UCSF, there is a pediatric clinic, and even at Valley Children's, the rates of obesity is a massive, especially the incline and incidence in young kids or kids and adolescent age period. And they're getting diagnosed with early onset type 2 diabetes, obesity, complications related to it, high blood pressure at age 12, 13. And obesity itself is a risk for low bone density. So two separate extremes, technically, right? One is low caloric deficit. The other is the lingering obesity because of our environment, lifestyle, biology. But both of them impact our bone health or impact the peak bone mass.
Yeah. I think it's super important that we teach maybe the grandmas and grandpas that might be listening to you just how important it is for their children to develop as much bone mass as they can in their growing years. See a lot of single sport athletes, kids that started swimming at a young age, and that's all they do. Be at a disadvantage if the land training isn't there, or the resistance training is not there. So it has been fun to incorporate some of these principles into our rehab for these young athletes that I see.
Yeah, that's impressive because they're getting their foundation laid and they're getting stronger. So, Dr. Robbie, if a duration, right? Like because we started with the LIFTMOR and the Onero program and why it's important to just get started, but with the right expertise rather than doing it yourself in terms of understanding your posture, balance, building muscle. What do you tell your patients or your clients when they're under your supervision, learning to get better in terms of their strength, their probably weights, and they're lifting heavier as they go along? I wanted to ask you to clarify this because the trial was 8 months, but this is something lifelong. So, how do you have those conversations with your patients?
Yeah, I just make sure they understand on day one what my intentions are. My intentions are to have a long-term supervised program. Will hopefully take it as far as the health insurance will allow, and then when people find value in it and they want to continue, we have monthly memberships. But this really is a program. It's really surprising how much troubleshooting we have to do. Even 8 months, a year into the program, I have people that come in after a vacation or after, cleaning the garage, and we have to modify everything for a couple of weeks and make sure that they're, allowing recovery time. And so being under the direct supervision of a physical therapist accounts for all of those little hiccups in life. When you have a long-term relationship to exercise, you get really good at modifying and figuring some things out, and that's hard to do. Most people just stop. And so, there is that long-term element, and it is a technical program, and so you should plan on having eyes on you and somebody there to program, to modify, to advance when you're ready, not when you think you're. I had one of our favorite lifters. She was so excited, like gung ho, and she wanted to progress, but she was not getting adequate protein intake. And I said, I am not adding weight to your deadlift until you hit your protein goals for 4 weeks in a row. Because I'm going to be breaking down, and you're not going to be replenishing and rebuilding. And so she hit her protein goals, and we've added weight to her deadlift. There's a lot of there's a lot of people who are motivated by that number, and we do have to pull in the reins a little bit sometimes. These are motivated people who are trying to do something that takes a lot of work, and so they kind of self-select into this program, and they're usually go-getters. I've got a couple that are, maybe they wouldn't describe themselves as that, but after a while, they get a taste of that accomplishment, that confidence that comes as you build a new skill. So it is a supervised program. Our intention is not to show you what to do at the gym. It is to have eyes on you, to be part of a long-term relationship and program, and, uh, they form these bonds, and the lifters, and the participants, have become friends, and they try to it's a lot of fun to see these, participants interact and, just support each other. It's a beautiful thing when they're there supporting each other.
Yeah, you're building a community also, that's so important.
I feel like the fly on the wall sometimes when they're all together and having a good time.
Yeah, no, that's amazing. Any last minute wisdom, thoughts, insights that you would want to give to the audience, including our male audience?
Yeah. I've seen the extremes in my family. My mother passed away at an early age, and because of her cancer treatments, she had fragility fractures in her pelvis. And I saw just how that really impacted her quality of life there at the end. And then my grandmother, her mom, is still alive at 102. And I see just how important her bone health is. She's fallen many times and has not fractured, thank the Lord. And so seeing these extremes, I think we do have a lot that's not in our control. Mom didn't have the ability to lift during her cancer treatments, but my grandmother has stayed very active and learned a lot from her. we have a lot of control in many cases, and getting the right help and having the right coaching, someone that's trained, perhaps in this Onero program or perhaps in other ways. This is not the one and only way to build muscle mass and bone density. It just happens to be one of the best uh, researched methods, and that's where I want to be. That's my space. Uh, but consistency is probably the secret sauce, and not treating yourself like you're fragile. Even we have had patients with fragility fractures just standing on the pickleball court and the femur broke. Long history, complex history, but she's here and she's moving and squatting and lifting. And it took a long time to get to know her well enough to even put a little bit of weight on her back. But now she's lifting 22 pounds across her back and shoulders and doing amazing. Big shout out to Linda.
Yeah, impressive. Impressive. Yes.
A lot is within our control. Get the proper help, the supervision. Try not to, DIY your bone health. Talk to the experts like Dr. Chhaya. Find someone that can help you with an adequately dosed exercise program. We under exercise, and for years I exercise these people afraid, more covering myself and not wanting to hurt somebody, because we've all heard the stories of the lady who broke a rib when she coughed, or putting on compression socks broke her spine. I have people like that coming through. So over the years, I've been a little reluctant to load these folks. But the Onero training really gave me the confidence, and the screening gives me a lot to go off of so that we can make an appropriate dosed program based on their starting point and where they want to go.
Yeah. The funny thing is I just recorded a podcast on, dose escalation for a certain medication. And here you go, you're talking about, the exercise part of it, but it's also a dose escalation of the weights or the training or, um, the movement that you're helping your patients and then building on it. And it needs the expertise. It cannot just be done, do it yourself or DIY, like you mentioned. So these are all gems. Thank you so much. If you can share your website or your phone number contact, we have lots of individuals listening who reside in Fresno, Clovis. That would be really helpful for them too.
Yeah, you are a bit of a celebrity here in the Central Valley, Dr. Chaya. Anybody I talk to uh, in the space, they know you and they respect what you're doing. Thank you for being an expert and for staying in the Central Valley. We hope we can keep you here for a long, long time.
Oh, absolutely. It's my community, and now we have, we know each other. So we build on prevention. We build on making everyone stronger. I think it's what RobbiePauline.com for your website. Okay.
Correct. Yeah, Mr. Y, Robbie with a Y, RobbiePauline.com. And we're located here in Fresno on Willow and Herndon. Our phone number is 559-257-3991. Drop in, say hi, take a tour, come and watch. We've got a pretty open door policy if you want to just come and see what's happening here.
There you go, people. You get a special invitation. So check it out. Really vetted, and I love evidence-based science and professionals like Dr. Robbie. So I really appreciate all the insights today, and hope we can help more patients and collaborate more. Thank you so much.
Thank you, Dr. Chai. Much appreciated. Thanks for your support and interest in what we're doing.
Of course, likewise.